helpful for our recording of the minutes. Secondly, when you aren't speaking, if you could just stay on mute to avoid some of the background noise, that'll help us as we get through today's meeting. With that, I'd like to ask Melissa to take a roll call for attendance.
Sure. Okay, we have Claudio Gualteri.
Here.
And Suchitra.
Yes, I'm here, Suchitra. Thank you.
Okay. Deputy Commissioner Jody Terranova.
Here.
Aisha Clark. Ann Foley.
I'm here.
Senator Tony Harp.
Here.
Parisa Charamchi Goodwin. Matthew Jasinski.
Here, good morning.
Andrew Solner.
Here.
Robert Boris.
Here.
Tricia Roscoe. Michael Rell.
Here.
Representative Cindy Harrison.
Here.
Great, thank you.
Great, thanks everyone. This is Claudio again. Agenda item number 2. In advance of today's meeting, everyone should have received the October 11th meeting minutes, the draft minutes for review. I'd now entertain a motion to accept those October 11th minutes.
So moved.
Thank you, Andrew. Motion is on the table. Do I have a second?
I'll second.
Second, Ann, thank you. Any discussion, edits, or changes needed to the October 11th meeting minutes? Seeing none, I'll ask that we do a voice vote to approve. All in favor of approving the October 11th meeting minutes, please signal by saying aye. Aye.
Aye.
Aye.
Any opposed? Abstentions? One
Claudio,
abstention.
yep, I just wasn't there on the 11th.
Okay, so noted.
Thank you.
The motion carries. The meeting minutes are adopted. Number 3 on our agenda for today, I just wanted to reset us on the conversation, the really robust conversation we had last time, get us in the frame of mind to be able to undertake our work of voting on the allocation agreements for this meeting. So last time we had some back and forth about the CDC best practices, reflecting that they really have been adopted. The last time was in 2014. I think subsequent to that, we all wanted to make sure that the CDC and public health professionals continue to look at them as the gold standard and the best practice. And so thanks to our Department of Public Health colleagues, they both did some research, DC Terranova and her team, and confirmed that there were a number of subsequent reports that all, again, reflect on and validate the existence and the support for the 2014 recommendations. So many times, even the 2020 reports from the Surgeon General and CDC documentations that have come out reflect back on the 2014. So we're pretty confident that the interval that the CDC has adopted, where we'll see some of these probably next year, you know, on a 10-year or so cycle, but still all recent publication, we can be confident reflects on the current CDC standards, and people in the academic world still view them as valid. And with that, I also want to just remind everyone that today we want to focus on engaging in a discussion and votes. We have a couple different votes. Our first set of discussions and votes, bless you, Ann, will be
Thanks.
around.
I thought I had my mic off. You just saw me?
I just saw you.
Okay.
The first set will just be looking from the bottom up at the priority areas. So the statute gives us an opportunity to give certain weighting to different priority areas within the CDC categories. And we just want to look at the 4 that are statutorily prescribed and then decide whether any other additional priorities we want to give weight to in the evaluation process. Once we conclude that and decide whether the 4 will be it or whether there's additional priority areas, we'll move to a discussion on the CDC practices and see how all those priorities fit into and roll up to the CDC buckets, and whether the changes in the priorities or where the board wants to head merits any change in the proportionate share of each of the CDC categories that we want to award for the allocation. We then have some very specific votes on some particular programs we'd like the board to recommend approving. And then we'll conclude with some next steps for the board's discussion. So with that, I'll turn it now to Deputy Commissioner Terranova, who is going to just refresh us on the CDC practices and the allocation chart. Before I do, Suchitra, do you have a question?
I do. Thank you, Claudio. So my question was about, are we focusing on the amount, the funds that we spoke about or discussed last time, or are we also including the Juul settlement funds in this discussion? Because we were sent an email about that issue. So that was my question.
That's a great question. We're going to focus our discussion on the $12 million that was deposited into the trust fund. By separate statute, the Juul settlements were coordinated through DEMIS and actually have already been allotted through a different process, but they're required to give a report to this trust fund. So that information you received was information about a separate process that's complementary to ours for the Juul settlement.
Thank you.
Anne?
So just as a follow-up to that, do we have the report about where the Juul settlement funding went? I don't know if I missed that or not. And the reason I'm asking is because it obviously impacts where we put our money. Do we want to double down on what they're doing, or do we want to fund things that they're not doing with that?
This is the reason I raised it too. It looks like the letter talks about where the money is potentially going to go, but it doesn't really provide any specifics about whether that actually happened. Thank you, Anne, for raising that.
Melissa, do you have any information? I know that we had received a request from the Attorney General to brief the board broadly, and we were looking at that for early next year. Any sense on the...
Oh, I'm sorry, Claudio, I don't have any audio for you.
Okay. Did you?
So I did send out, the whole board should have received as part of an email that had the October 11th meeting materials and everything, the report from regarding the Juul settlement was in there. And that's the only report we have. We are having them come, the AG office is going to come brief us on the Juul settlement at our April meeting.
I would also, this Claudia
And
again,
we
I would
have
also
DEMIS
advise.
coming in January. I'm sorry, I forgot to mention that part.
Yeah, I would also advise that the board not put too much stock in that because proportionally speaking, the Juul settlement still has some potential obstacles, right? Juul may end up going through a bankruptcy procedure. It's hard to see what if the final amount of those dollars will materialize and how they'll come. So I'd hate for our dollars, which we have that are very secure right now, the 12 million that we could put in, that we should do our process. And to the extent I think that we'll be ahead of them, we should encourage the Juul settlement dollars to wrap around ours. I'd like ours to be the anchor. We're the ones that sort of have some more concreteness at this point.
Sorry, Claudio, I think that's fine. So Juul is not Juul anymore. You know, they've been bought over by a larger tobacco industry. So I don't know why they would go into bankruptcy. So that's an interesting point that you raised there. But that's another topic for another conversation, I suppose. So.
Anne?
Yeah, so is there someone from DEMIS who is on this board or who is following our work, so they'll bring that back, or you're going to bring that back to DEMIS and ask them to proceed in that fashion?
We've been a conduit with DEMIS and the AG, which are partners but not part of this board. So happy to do that. We will follow up with Kelly Cinco in the planning for the next DEMIS behavioral health presentation. So one thing that came to light at the Alcohol and Drug Abuse Task Force was that a number of the regional behavioral health organizations across the state have identified vaping as a top risk factor, almost uniformly across the board. And then among the top 10 issues that they've surveyed and found as being local community need, they've also identified tobacco. So we thought it was very important to tie some sort of a connection, a strategic initiative to the work that's happening through Demas's behavioral health organizations and overall planning with this board. So that's why we had already initiated a conversation with them in January, but this will be part of the planning meeting that Melissa and I have to make sure that they tease out any update on the Juul settlement, and then having the benefit of seeing our allocation plan could make commentary on how they'll work to fill in additional gaps.
Thank you.
With that, I think DC Terranova, you're up on a refresh of the CDC.
Thanks, Claudio. Good morning, everyone. I am going to pull up the pie chart that we were looking at last meeting, just as a refresher here. There we go. Just to remind us what the current CDC best practices recommend for percent allocations for the 5 big buckets for a comprehensive tobacco control program. So you'll remember that we talked about the state and community interventions. A lot of that was focused on local health departments and their work in the community level. Infrastructure and administrative support, so that's staffing support to help run these programs, put out the RFPs, do the contracting, collect the data. And then our mass reach health communication piece is basically what it says there, the communication aspects of the programming. A lot of times we've used this to focus on education around access to the quit line, and we've seen corresponding increased usage in people calling into the quit line when we're doing a media campaign push. The largest bulk is into cessation interventions, approximately 40% there. And that, again, mostly we have used that for Quitline over the years, but then also other campaigns as well on colleges to help advocate for cessation programs and other things in the communities. And then the last piece is surveillance and evaluation. And, you know, in the past, we've done this in a few different ways. Some of that kind of contracting out with a vendor to do a comprehensive evaluation. We've also used surveillance money to do our own internal surveillance, adding questions to our adult and youth risk factor behavior surveys that are conducted across the state to get a sense of what are the percentage of people that are using tobacco products and those that have attempted to quit and their success rates. So those are kind of the 5 big categories that we have to work within. And we talked about in the past, you know, the last meeting, did we want to maybe shift any of these if we thought they would be more relevant to our state to maybe spend a little more or a little less in a category? And I think, you know, to Ann and Suchitra's points, you know, thinking, you know, in the future when we look at this, if there's a lot of money going towards vaping, maybe we look at reallocating. But for now, I think we really focus on these are the percentages recommended, and do we feel comfortable here, or as we have our conversation today, do we want to adjust these numbers at all? So I think I will end this part here and see if there's any questions right now about this. And I think Claudio, even before we talk about this, we'll do a little more discussion about the priorities, correct?
Mm-hmm.
That's right, DC Terranova. Dr. Sellner, I see your hand up. You have a question?
Thanks so much, Claudio. Good morning to all. Quick question, which gets back a little bit to the Juul question, which is certainly a youth issue. And as much as cessation is key for all of us, the question of prevention, either through educational aspects or more specific community outreach. And I am assuming that prevention sort of fits in both the mass reach health communication bucket as well as in the state community intervention bucket. So that's where prevention would be, and that's where we might potentially overlap. We could overlap with cessation with Juul because, you know, a lot of those kids are really addicted to nicotine and they need cessation assistance. But thinking about the prevention piece, I'm just assuming that it fits in those other 2 buckets.
Yes, I would agree, Dr. Selner. I think that's correct. That the prevention, most of our prevention work to date has been done in the state and community intervention piece, with some of that being communication efforts as well.
Thank you.
All right, this is Claudio again. I think that will bring us then, now that we've level set on the CDC practices, to our next item for agenda, which is, as referenced by DC Terranova, we want to look at the priority areas. So statutorily, there are 4 prescribed priority areas. Those are ones that we would give additional weight to as part of the evaluation and RFP awarding process that's happening at DPH. But the statute says that we must prioritize these, but it does not limit us to only these areas of prioritization. So we want to take just a quick few minutes to refresh us on the statutory prioritization areas, and then entertain a conversation about if these we believe fully cover where we want to put priority dollars, or if there's additional priorities not reflected by the 4. The only thing I'll say as an umbrella comment is every time you have prioritization, the more priorities you add, you by necessity dilute the existence of the 4 that already are in place. So we have to do a little bit of a balancing act. A prioritization list of 8 to 10 will probably not mean as much as sticking closer to the 4 that are statutorily required. So you see on the screen here the 4 areas, which is prevention of initial tobacco and nicotine product use among youth and young adult. Number 2, smoking cessation directed at adults and youth. 3, elimination of exposure of secondhand smoke and aerosol. And the 4th, identification and elimination of tobacco and nicotine-related disparities. I'll note that I think Dr. Selner made the good point of how disparities is feeling much more like a cross-cutting initiative that could go into multiple buckets, and it could be built into a host of different interventions. We would just look for some subset of specification on targeting for different disparity groups. And then the last obviously being a prioritization for matching funds, a consideration of matching funds. We always look for better ways to leverage the dollars. I'll pause there and ask representatives of the council to raise their hand if they wish to discuss, 1, any questions to these, and 2, more importantly, are there any thoughts on additional priority areas that you'd recommend? I see Senator Harp has her hand up, so I'll recognize her first.
Oh, thank you very much. You can just call me Tony Harp. I haven't been a senator for a long time. When under prevention of initial tobacco and nicotine product use among youth and young adults, how are we defining youth? What are the ages?
It's a good question. DC Terranova, do you have any sense from the CDC? I would assume it's 18 and under, but is that more just an operating rule of thumb, or is it prescribed?
Yeah, I think youth is up to 19. I don't know if statutory language defines youth here, but I think youth, and then young adults is usually up till 26.
The reason that I asked, and I don't want to keep going on, is that if it's school-age children, I think sometimes actually getting them in preschool and helping them to understand is really important. I remember that it was an important mantra back in the day when my kids were in I would say like between 4 and 5, that they really sort of it was a big initiative and push. I don't know who did it, but I don't want us to forget about early childhood learning around prevention.
Yeah, I don't think there's a lower limit on the age question, which now I'm understanding what you're asking. Yeah, I think youth could be right from the earliest school ages and up.
Okay. I just think that we need to, that's a huge number of years, and that we need to make sure that we get the most out of the program for all of the years, as young as is reasonable, all the way up, I guess, to young adults. That's all I have to say.
Thank you. That's a great point, Tony. We will reflect it contextually when we submit. So just so that the board is aware, we're putting together an allocation plan based on these votes that will be transmitted to the two committees of cognizance in the legislature for final approval, those being appropriations and public health. So I think it's totally permissible for us to unpack some of our understanding about it being including very young individuals where that makes sense. And we could just say our understanding is the sort of 0 to 18 and where it's beneficial to start earlier. And there's evidence to support that we would encourage those programs to be part of this priority group as well. Okay, I'm seeing Dr. Salner and Suchitra. Andrew first.
Claudia, thanks. Two points to make that might suggest two modifications of this or suggestions. The first one is in communications methods. It says smoking cessation directed at adults and youth, but it doesn't mention vaping there. And can we assume that wherever it says smoking, it would also include use of nicotine products, or do we need to add vaping, which is a big problem for youth, in number 2? That's my first question. My second one is, under cessation interventions, it says elimination of exposure to secondhand smoke and aerosol. And it doesn't mention more individualized programs for cessation, like a program specifically focused on a population like patients with mental health disorders in an outpatient clinic, or whomever, whatever the situation is. And so therefore cessation is really only, even though that's 40% of our budget, cessation itself is only mentioned in number 2, even though number 3 says elimination to secondhand smokes. That doesn't imply a direct program for cessation to specific populations. So I would suggest that we might consider under number 3, that elimination of exposure to secondhand smoke and aerosol might include individual cessation programming.
Good point, Dr. Salner. If I could just press a little, do we think that number 4 bootstraps into your intent there by looking at specific disparities? And if we could just define disparities as broader, including the subpopulations that you had mentioned, and that be sort of a cross-cutting way to get at the initiative?
Yes, except that surveillance and evaluation only represents, 9% of the budget, whereas cessation represents 40% of the budget. So if we're going to really reach specific populations with cessation programming, I think it needs to somehow be added to number 3. And maybe it's implied under an elimination of exposure to secondhand smoke, but I'm just thinking that we need to say that elimination of exposure to secondhand smoke is inclusive of cessation programming.
Can I ask whether you'd be willing to, because I'm hesitant to add to the statutory changes unless we add a brand new category. Could we then just add to 4 that this also includes an understanding of disparities as they relate to cessation, initiation, and elimination of? Can we broaden 4, I guess I'm suggesting, with a clarifying statement so it doesn't feel like we're adding a new category?
Yeah, my only concern is that the CDC recommended budget for 4 is 9% or whatever, and that's around the evaluation and surveillance piece. It's not really around the intervention piece itself. And that's why I'm just
So maybe I should point up a clarity. I think when we have both, if you're looking at the slide that has the crosswalks, that's not meant to be a crosswalk to the priorities. Those are two independent charts.
Okay,
So I should have, and I appreciate Ann flagging for me that it may seem like we're trying to crosswalk, but we should have probably put one on top of the other.
okay,
So it's not it's not to say that cessation is equal to priority 3. Those are independent subsets.
so does that mean that under number 2, where it says smoking cessation directed at adults and youth, that could cover more than just communications method, that it could also cover the cessation intervention bucket?
Yes, exactly as I understand it.
Okay, then I'm.
But appreciate
fine.
you calling it out, because if others were not clear on that point, you just give us an opportunity to clarify. So these two are not crosswalks. So identification of disparities can be evaluation and surveillance, cessation, communications and dissemination, as well as our state and community programs. All 5 of the CDC buckets, as I see them, can be part of the priority area for disparity.
Okay, then I'm fine with that issue, and my only other question would be where we make sure that vaping interventions might be included. And I'm assuming, since it says nicotine control programs, that we can assume that smoking cessation directed at adults and youth would include use of vaping products?
I think so. I look to the board if they have any objections to that. I know that we did a lot of work statutorily to try to make it clear that the whole objective of this board is broader than just tobacco, and to include nicotine products and vaping. That was the major thrust of our refresh. So I think implied in that legislative intent is that we'd carry through that understanding across to the priority areas. Certainly worth making a note, though.
Thank you.
And I'm recognizing for the group that Representative McCarthy Vahey, chair of the Public Health Committee, seems to endorse that concept of making sure that our vaping focus carries forward in the priority. So that's about as good as you're going to get for legislative intent in real time. Suchitra, can you have your hand up?
Yes, I do. Thank you. So I completely agree with what Andrew just said about the terminology there, and I'm going to suggest, I'm wondering if I could suggest a little bit of a change in terminology to actually use words like combustible and non-combustible tobacco and nicotine products instead of smoking cessation, because one of the problems with the CDC guidelines is it was done in 2014 when they were really just drawing from the smoking literature. And since then, there's been a huge focus on use of cigars, use of smokeless, use of all different kinds of products, even among youth and adults, which doesn't really, is not covered by this. So if we say something like smokeless, combustible and non-combustible tobacco and nicotine products cessation, that may actually cover it a little better. And the other reason I'm putting nicotine in there is because, to go back to the discussion of vaping that we just had, a large amount of vaping in schools is not just nicotine, but is also marijuana. And this is one of the problems with the FDA dollars and with the work that's ongoing with the center that I lead at Yale, is that we can only address tobacco and nicotine specifically with the dollars. I don't know if those kinds of restrictions exist on these dollars also, or whether we can cross into this area of marijuana vaping, which is also large. So I think just thinking a little bit through that and what we would be accepting would be a good idea.
Those are interesting points, and I'll entertain if the board has any strong feelings one way or the other. I think the combustible, non-combustible certainly can be understood in the context, and we can point in that direction when we make the allocation recommendations to the legislature. On marijuana, cannabis, I would steer slightly away from it just because there's separate social equity funds and dollars that have been appropriated to look at the specific impact of that. And I would hate for our money to be diluted. Certainly, I think to the point that was made earlier about understanding the jewel, I think once we have our plan, continuing to have conversations so that we're all working and rowing in the same direction makes sense. But I would leave primary focus to that pot of money.
I think that makes sense, Claudio, if I can jump in, because that's the way the FDA has handled it too. But they have sometimes it gets a little difficult because the behaviors kind of go together. But I think that makes sense because we only have a set amount of funds, so it makes sense to focus it on tobacco and nicotine.
And I do think you're hitting on a broader point that we had talked about early on, that this committee maybe wants to have an ad hoc work group to think through any legislative changes, either refreshing our board's mission or tightening up the membership. I'm hearing maybe some interest in having Demas directly included as part of this board would be smart. Maybe to the point that you're saying, maybe someone who's representative of the work on the cannabis being part of it. If not that, maybe a consultation function written into the statute or into our practices, just so that we can have an informal network that we're sharing and all sort of adopting the same general direction of these resources. I think that's a really good point. Anne.
Thanks, Claudio. And I want to apologize to Jody because she probably covered this in her presentation, but I totally missed it. But to the point of the CDC allocation recommendations being from 2014, I know that last time we met, Jody was going to reach out to CDC and see if they have an update for us. You probably covered that in your presentation, but can you just say again whether you did that and what they said and when the new allocation recommendations are going to be coming out?
Sure. I think Claudio actually covered it, so you don't have to apologize to me.
Okay. Well, sorry, Claudio.
Yeah, so we reached out. We didn't get a date onto when the next revision would be available, but we did send out reference materials to all of the members of the committee with 4 different interim guidance materials that have come out over the past few years. The most recent was 2021, and that was about putting evidence into practice and how to use evidence-based practices following along with those 2014 recommendations. There was one related to youth engagement that was from 2019. There was one on an update on cessation from 2020, and then communication from 2018. So 18, 19, 20, and 21, they had kind of updates on different pieces. So we're hoping they'll get the new full revised plan out in the next year or two, but they didn't want to give us a firm date on that.
Okay, thank you for that.
All right, this is Claudio again, recognizing we're still on track with our time, so we're doing good, except I just want to see where we're at in terms of consensus. So what I'm hearing is that there's opportunity for the board when we're submitting our allocation recommendation to just sort of unpack and provide a little bit more granular detail on our understanding of the specific priority areas, but I have not yet heard that we wish to add any additional priority areas, and that our understanding is that some of these priorities can be cross-cutting and fit into multiple of the CDC required funding buckets that we'll discuss later. Is that generally capture where we are? Can we maybe consider entertaining a motion to formalize that these 4 will be the 4 for this round of funding?
So moved.
Thank you, Andrew. Do we have a second? So the motion is to ratify and support that the 4 priority areas will be the only priority areas going into this round of funding. I have a motion. I need a second.
I'll second it.
Thank you, Michael. Any further discussion? If not, can we take the roll? Melissa, can you take the roll to confirm?
Yes. Claudio Gualteri.
Yes.
Okay. Suchitra Krishan Sarin.
Yes.
Jody Terranova.
Yes.
Ann Foley.
Yes.
Tony Harp.
Yes.
Parisa Chamchi Goodwin.
Yes.
Matthew Jazinski.
Yes.
Andrew Solner.
Yes.
Robert Boris.
Yes.
Michael Rell.
Yes.
And Representative Cindy Harrison.
Yes.
Did I get every member who's present? Yes. Okay, it passes.
All right, that's great. That brings us to the next item. Now that we've had a conversation and confirmed our priority areas, we need to consider and then take a vote on the allocation percentages in the CDC pie chart. And DC Terranova has already given us a little bit of background. We've had some discussion on that. I think now, do we want to put that back up just so that people can see it and we just talk through how some of the priority areas fit into those CDC practices? And for that, I'll ask DC Terranova maybe to help lead that conversation.
Sure thing.
Oh.
All right. So here we are with our pie chart. So I guess really I would open it up to the floor to see if anyone has any recommendations at this point, Claudio, as far as making any changes to the current recommended allocations.
I'll start with an observation, DC Terranova and group, correct me if you think otherwise, but I just want to confirm for the record that there are types of programs or initiatives where I could see falling into multiple of these. So it's a little bit more of an art and a science as to where we ultimately attribute them. So for example, even taking Tony Harp's good point about how we get to early intervention among children and stopping them from initiating smoking, I could see a component of that being communication and mass outreach that's targeted to young children. I could see it. Oh, there's a little bit of background noise. If I can ask someone to mute.
Yeah.
Thank you. So just reconfirming my understanding is that something like that could fall under, there could be a communications component, there could be disparities among youth. So I could see it being part of that priority area in our community and interventions and state-based interventions. The assessment of how effective it was, I could see being partly attributed to surveillance and evaluation. Obviously, any program we do is going to need some administrative infrastructure and support. And on this one in particular, probably cessation intervention doesn't make sense because we're trying to stop them from smoking on first instance. But otherwise, I could see that type of initiative falling in multiple of these CDC best practice categories. All right, so Suchitra, can I'll recognize you?
Sorry, thank you. I think this is great, honestly, but I had a question. So when they see surveillance and evaluation, the CDC is also talking about use rates and things like that, right? So, and the CDC by themselves does things like surveys like the youth risk behavior surveillance, which is a separate pot of money, I'm assuming, that comes from CDC for doing that work. Do we want to be specific about what surveillance and evaluation means here? Do we want to focus more on evaluation? What are we really focusing on here? Evaluation of programs, surveillance of prevalence rates? Just a question, because there are larger initiatives that get at, I think, prevalence rates.
So I think that just to take a first stab at answering that, one thing that I would like that to see this group do is to look at doing what happened in the first iteration of the board, which is a holistic review of all the investments that we've allocated and their effectiveness. So I understand your point about population health, and I think that could be an important component of additional evaluation and surveillance. I'd like us to take a look at what did we fund and what were the results of it, so we can start telling a compelling story of resources equaling impact. But I recognize that if we're putting 9% of the 12 million, that's over $1 million. So we may be able to do that plus do some of the other things. And my preferred approach would be that we would go to an RFP and sort of list out the priority areas, list out some specifications of ones that must be done, like evaluating the programs that we fund, but then opening it up to the bidders to see what additional surveillance or evaluation activity they would recommend, and let the scoring committee sort of do that through a very thoughtful process. And if you're interested, we're going to talk later on about how members of the board, as long as you don't have a conflict of interest, can be part of any of the RFP writing committees with DPH to scope out the type of services that we're requesting and how we're going to evaluate and rank the applicants.
I would
Thank you.
also add, in addition to, like you mentioned, prevalence, surveillance could also include surveying changes in behavior or attitudes towards
Mhm.
tobacco use over time, as well as measuring health outcomes and changes in health outcomes with cessation. So there's definitely other things that we could surveil in addition to just prevalence rates.
Thank you for that. I completely agree. From my own perspective, I think we have a lot of great data on youth because the CDC does a great job of assessing that, but we do not have very good data on adults, and even less in minority communities. We have very little of all that information. So I think we should definitely have that piece.
Excellent point. And that speaks to how the prioritization about disparities maybe needs to be front and center when we look at the surveillance and evaluation piece. Robert.
Yes, I just wanted, maybe this is too far in the weeds right now, but under that surveillance and evaluation piece, is that including efforts to synergize with other New England states doing the same tasks as we are here?
I think that certainly could be, especially if there's an evaluation component that provides recommendations like that. I think that would be quite useful. I think too, Claudio, maybe just for a clarifying point, that we're voting on these recommended percentages for this round of funding, but really this is something that can be readjusted with the next round of funding. So, we may learn from things as we go along too, and say, oh, this past year we put a lot of money into the evaluation piece, but that's going to be ongoing. So maybe now we can put a little bit more over in communication or vice versa. So I want people to remember about that flexibility too, that we're not stuck to this forever.
Excellent point. Yes, that's one of the advantages of being an iterative body, and we can refocus where needed. Tony Harp, I'm sorry. I know you were up before. It looks like the previous speaker, so apologize for overlooking you. You're ready to speak? I'll recognize you now.
Sure. I guess for me, the real question is, what is already being done in this area? Who is doing it? And what benefit, besides sort of looking at our own programs, which Claudio, I agree with you, that's really important. But in terms of surveillance, you have it at multiple levels already. You have it at the state level, the federal level, and the local level. And I think before we spend, like $1 million in this area, that we really need to know what it is that already exists and how what we would do would add to our understanding of the problem and solutions of the problem. And so I'm thinking that we don't need to put all of that there now, that we can use the recommendation that was made previously once we have a better understanding of what already exists and what needs to beyond looking at the programs that were funded previously, and put some of those resources into community intervention or cessation, or actually even communications for our young people, so they don't get started in the first place.
Yeah, this is Claudio again. I totally concur. I think that you're raising a point. You're wearing your old appropriations chair hat of making sure that we're squeezing out every dollar and not being duplicative. And I very much appreciate that. My understanding, I guess, is that we would do that through the scoping of the RFP process, that they would have to show, and we would rank people based on not duplicating or having a synergistic, being able to pull in resources that are already committed and doing some additional work, having a better ROI, and that would be part of the evaluation and the scoping. Certainly, we would not want to fund things that are, supplanting funding that's provided through certain block grants, for example, at the federal level, or through other federal CDC grants that DPH provides. And I think that as a standing rule, we would work with RFP drafting committees to ensure that there's something called out of what you're currently doing, a landscape analysis, and how you fit within that landscape, not duplicate it. But very, very good point. Andrew.
Thanks, Claudio. I just in response to Tony's comments, while I support the notion of being careful with the dollars that we don't spend on interventions, I think it's also important to note that evaluation of the programs we fund is really important. And many organizations that don't put adequate dollars into evaluation don't really get a good valuation, and they're left, with their arms up in the air wondering what the heck did we do? And most programs out there recommend approximately 10% for evaluation of their programs. So I'm not saying that we should or shouldn't spend 10%. We could see what kind of responses we get to an RFP on evaluation, but I would just express a caution that if we try and carve out too much out of evaluation, we won't get a good evaluation. So we just have to be careful about that.
Thank you, Andrew. Anne?
Thanks, Claudio. I actually took Tony's comments maybe a little bit differently than Andy did. And maybe this question has been answered before, but of all the, the other funding sources that we have available through the federal or state government, which of these categories are we focusing them on? Because if, we have significant other funds that are going for instance, cessation interventions, maybe we would want to, cut that down a little bit and put a little bit more money in one of the other categories. So I don't know if that has been answered in previous meetings or in materials that you've sent out, but I do think it is kind of an important piece, and not just for surveillance and evaluation, but overall the piece of the pie. Are we already substantially funding one of the areas or none of the areas, which obviously may be the case?
I could speak about what DPH has for CDC funding for this, because that's probably the only other real federal resource that I know that we have. And so we get about $1 million a year. Some of that we use for the quit line, and then about half of that we use for staffing for our tobacco program. And about 200,000 of that goes out for contractual work for other program stuff. So there's not a lot of money compared to this amount of money that we have from CDC for funding tobacco work.
Okay, that's really helpful. Thank you. And just one other quick question about, I know we're looking at 12 million overall. Don't we have another 12 million for this year? Or I thought the 12 million was for last year and we have another 12 million this year. Or am I wrong?
Good point of clarification. So the deposits happen each April. So we have a deposit from April of 23 in there now. We won't get another deposit until April of 24. So it happens sort of towards the end of the fiscal year. So the
Yeah.
allocation that we're doing is from from this April.
Great, thank you so much.
Yeah. So I heard some consensus on surveillance and evaluation. I want to try to take a pitch at summarizing what I heard and maybe putting it into a motion. I think that there was general agreement that evaluating our programs, the specific things that this board is going to initiate and fund, is an important piece of our work, and sort of directly having some evaluation, make sure it's successful, and where it needs to be refined or changed is an important use. I'm hearing a little more skepticism on surveillance broadly. So I wonder if the group would be willing to carve that 9% down and just make it specific to evaluation of our programs on first instance. And then if we need to, if we find in the future to do more of a broad-based surveillance function is worthwhile, we can always add it. Anne.
I actually feel differently. I think surveillance is important, and I know there's other surveillance going on, but I really liked what Jody said about there are other kinds of surveillance that we could do that are not necessarily prevalence, but might be attitudes or other things that would be helpful to us. So I kind of like the idea of having that category broad enough so that it includes surveillance as well. I mean, I don't know. And if I'm the only one, that's fine. I don't mind being outvoted. It happens. But that's how I feel.
All right, Andrew, and then Suchitra.
I guess I would agree with Anne. I think the idea of having some dollars there, for example, if the company that we hire to help us with ads for youth wants to do some kind of survey to find out how do youth feel, or what's the best way of reaching youth? Is it social media or whatever? Or what if they want to find out a little bit more about young adults? And surveillance is a piece of that. It gives us a chance to wrap that appropriately into that budget. So I guess I like the idea of having the flexibility of having some surveillance as part of a primarily evaluation kind of piece of the pie.
Good point. I hadn't thought of it that way. I appreciate you braiding it back into communication, because if we're just doing some blind communication, open-ended, not very targeted, not looking at survey work, it's not as effective. So I thought that's a good point. I hadn't thought of it. I know that's something that is worth considering. Suchitra, your hand, and then Tony Harp.
Yes, hi. So I started this beast. So let me just say my intent was certainly not to suggest that we should not put money into surveillance. I think surveillance is important. And for another example I can give you is there are a lot of legislations going into the Connecticut legislature around tobacco products like flavors and menthol and so on and so forth. I think surveillance of people's attitudes and towards these legislations, towards these products is going to be super important to support some of these legislative, agenda and ventures. So I think we should have some component of surveillance. I was just talking about the more traditional prevalence rate surveillance, which I think is done quite a bit, but there is so much more that surveillance can cover.
Okay, and true to group decision making, they say one of two things you can do: either catch something that everyone agrees on, or catch something that no one agrees on and push the group into a decision. And I think at least we're approaching a decision. So Tony Harp, did you have a closing comment here?
Yeah, I think that what I was saying, that it's important, and I know that we don't meet often, but to just understand from a traditional way of looking at surveillance, which is how I looked at it, what else is out there and by whom. But the more non-traditional that I'm hearing that people are interested in, I think is something that we should do. But I do think that there is a way to do a healthy evaluation of both past programs and current programs, as well as have non-traditional surveillance, which would be interesting and can inform what we do in the future, working together. And so I was never suggesting that we just do evaluation, but I do think that we need to look at what we've done in the past and what's worked, and then use that to inform what we do in the future.
I have Representative McCarthy Vahey, followed by Robert Boris.
Thank you, Claudio, and everyone. I've been listening in, and I recognize I'm not a voting member, and I appreciate you letting me chime in to this conversation. I will support the comments of the last few folks who have been talking, starting with Anne. And one of the things that I'm interested in is how we're complementing efforts and funding that's being done at the very, very grassroots level. And I know sometimes we get siloed in our work because of the way our funding streams work, but I just want to kind of raise that awareness, just even at the very local prevention council level, with the conversations we're having around youth vaping through the local prevention council grant. So wanting to make sure that there is a way through the use of these funds to braid those things together, to use your word, Claudio, and I think that's what this conversation would also allow for. Thank you.
Excellent, thank you. Robert?
Yes, am I correct that the surveillance and evaluation is within best practices range for outcomes? It's usually between 5 and 10% for programs like this, and in this case, it seems like it's proportionally allocated. Is that how the number was reached? And it seems reasonable if that is the case.
Good question. DC Terranova, do you want to just confirm that to be the case?
Yes, yep, yeah, that is a common practice, and that is what CDC is recommending for this category for this type of work.
Thank you. I know in the chat there was a good comment made, and I think it may summarize what we've been discussing. I think that across the board, the Tobacco Trust Fund Council here really wants to make sure that in writing the RFP and when we're evaluating where we spend money, that we ensure that there's some specification in each of these. And I think that some of it's going to be focused on the type of evaluation, the type of surveillance that we want, some of those new methods. I think additional pieces that I heard is we want to make sure that there is a very clear connection between the work here and other existing work, or a commitment by the applicants to work to connect the interventions that we fund to existing resources and or state agency activities and initiatives or community partner initiatives. And so what I would recommend is that to me, those feel like operational decisions that move to the next phase of our work, which is not the broad-based allocation of buckets, but when we write out our expectations for applicants for these funds, the type of requirements and point allocations we want to give can reflect the conversation that we all had here this morning. With that, I do want to recognize DC Terranova, because I think within the cessation space, we want to potentially recommend and vote on a specific allocation amount for Quitline. So DC Terranova, do you want to talk us through that resource, some of the evidence behind it, and the need upcoming to continue funding that important work?
Sure. Thanks, Claudia. Thanks for the opportunity. So some of you may be familiar with Quitline and some of you may not. I think, before I joined the Department of Public Health. I knew it existed, but I didn't know exactly what it did. And it's a service we have provided for a couple of decades now. And individuals can call the Quit line for help with quitting smoking, not only to talk to someone and get advice, but to actually get nicotine replacement. Currently, we've been offering up to 8 weeks of free nicotine replacement products that are mailed to the individual, so that they can have access to not just speaking to someone, but to actual tools that will help them quit smoking. We've had great success with the Quit line, although we've not had great success with usage, like the number of people that we always can access. And we have seen over time when we do a big media push and highlight the Quit line and re-advertise it, we do get a big uptick in usage. And so kind of over time goes up and down. We have contracted out for these services over the years. Our current contract is a 5-year contract that's expiring in the spring. We actually put out our RFP this previous spring, because as you guys will remember, we talked about the last meeting, but the timeline for putting out an RFP and then finalizing your contract takes, more than half a year, 9 months sometimes or so. So our staff started in this spring to write the RFP to put out for a new bids for vendors for our Quit line services. Our Quit line is available for youth and adults, but we only send the nicotine replacements to adults who are 18 and over. So we concluded our RFP in the summer and selected a vendor and are currently working on the contract, but need additional resources for our contract before we're able to kind of move forward in our next steps. In years past, this has been funded partly by that CDC money and that I was telling you about, that we get, $1 million. Of that, there is a component that can be used to fund the Quit line that is capped, and so we use $100,000 from that to fund our Quit line. And then we've always supplemented funding for the Quit line with trust fund dollars in the past. And so we're looking for the trust fund to allocate $500,000 for this next year to be able to initiate a new contract for the upcoming year. It would begin in May to allow some overlap so that our service doesn't end with one vendor and start with another. We would allow for an overlap for people that started with the current Quit line to be able to finish with the current Quit line in their 8 weeks time period. So we, I guess, Michael, I'll let you ask your question I see your hand. Oh no.
DC Turnova,
Rep Harrison. Yeah, go ahead.
Yeah.
Yep, Rep Harrison was first. Go ahead, you can ask your question.
Thank you very much. My question is, while we're doing this and we, getting the products out, and listen, I applaud that. Are we getting any feedback as to success rates with those products?
Yeah, so we do have some data on that, and actually, if you look back at the previous evaluations as well, Quit line is one of the things that does have a pretty good success rate. I don't think that we have data that tracks people out longer term, but at least in the short term, there is a good success rate for quitting, at least temporarily. And some people are repeat users of the Quit line because it takes multiple attempts to completely stop smoking for a lifetime.
Okay, so then my next question, I completely understand, we want people to be over 18. What can we do to help people who are under 18 to also quit? I think that we want to be able to somehow make these products available to them.
Right, so they're not FDA approved for under 18, so that's a little bit tricky. And I'm a pediatrician, so I understand, like I had patients, right, where it's a little tricky where you could, certainly use something off label, but as the state, we can't dispense them to someone under 18. Certainly they're given advice that they can talk to their provider and ask for these, but we can't dispense them to them. We do offer additional services targeted at youth. In addition to separate from the quit line, we have a texting line to help quit vaping in particular, because that's a much higher use in youth than actual cigarette smoking is. And so we have that as a resource for them as well, because they, teenagers are much more happier texting than talking to somebody. So that's available.
So is there anything that we can do to link these products and make them available if they're doing them through some kind of a provider, understanding that they're under 18?
And link them to the quit line?
I think maybe I'm not making my question clear. So you're saying that, they can do some work through a provider to quit. Can we make these products available to them if they get them through a provider? In other words, I'm trying to look at, the fairness of our dispensing. We're doing it for adults, and we're doing it free. Is there a way that we can do it perhaps through a provider who's monitoring them because they're under 18?
That's a great question. Yeah, I don't have the answer for you today, because I think we'd have to look into the legality of something that's off-label usage. Yeah.
Right. But yeah. Okay. That'd be a great thing for us to explore. Thank you.
Great. Thank you.
And Deputy Commissioner, just to go back to the funding, the $100,000 from the CDC, that, I guess, what is the total amount for the quit line budget within DPH?
So that varies, because we get billed by usage, by the number of callers that come in. And so in years past, that has ranged. There's been, allocations from the trust fund over years that has ranged. And so we have flexed our program to meet the dollars that are available. And so when we don't have as many dollars available, instead of offering up to 8 weeks of nicotine replacement, we might only have offered 2 weeks. So it has adjusted that way. Currently, we are running about a monthly bill of about $35,000 for the quit line. And as I said, that kind of goes up and down with media campaigns and pushes. So I would expect when we have an influx in money to do more communication with this next cycle, we'll have an uptake in usage of the quit line. And so that monthly number may go up, but the last couple of months have been around that.
And then the 500,000 from the fund, is that for the life of the contract, or is that annual?
That would be annual, and that would cover the cost that we're talking about. And one thing that we would like to consider expanding, again, depending on available dollars, and we'll, cross that bridge when we get to it, but making an electronic referral available for providers to refer patients to the quit line, rather than putting the onus on the patient or the individual to call the quit line. So now the quit line could call the person. If we're able to link to electronic medical records and have providers be able to put in an e-referral right to the quit line. So that's something we're hoping to be able to do with our current vendor going forward, which would then, again, hopefully increase usage and access to the quit line, which would then increase our monthly costs. But for now, to keep things kind of where they're at, the $500,000 would continue kind of our current services, and then we could discuss in the future what other opportunities are available.
And then my last question would be, what percentage is it for outreach versus the materials, the 2-week to 8-week cessation materials?
What percentage
of the, say, $500,000, what percentage would go to publicity, marketing, and outreach so that more people know about the quit line? And then I guess, as you said, as more people know about it, then the cessation products would be, an uptick as well. But I guess I would want to know, how much do you think would be required for publicity or outreach for the quit line?
So that would be separate. I think all of this money would really be used for individual services because our contract with the vendor would be to provide the services. They wouldn't necessarily be the ones doing the marketing and advertising. We kind of have been doing that separately within our section. So that would be from our communication dollars.
Okay, gotcha. Thank you.
Thank you for the questions. Dr. Salner?
Thanks so much, Deputy Commissioner. Two questions for you and for Claudia. The Tobacco and Health Trust Fund, from what I understand, includes dollars that come through from the tobacco settlement. And that's, I think, something like a couple $100 million a year. 12 million of which comes to us, thankfully, to the governor and the legislature to use for the purpose of these programs. And the rest of it gets swept either into the general budget or put into special activities that you all designate for the trust funds to be used for. Is there any reason why, and I fully support the quit line, and I think it's, you know, a very successful, from my experience and the experience of my patients, it's a very successful program and does well. So I think we should support it. I'm just wondering whether the $500,000 should come from our $12 million of the trust fund or from the other 188 million that comes through the trust fund that gets swept out into other places. So this is more of a procedural question, if you will.
So maybe I'll start there, Dr. Salner. One, I do want to just clarify that the monies that were originally part of the master settlement for tobacco, unlike some of the newer settlement agreements like opioid, did allow for states to get recompensated for Medicaid costs and other healthcare expenditures that happen as a result of tobacco smoking. And the other point I would say is that these funds need to be looked at in the context of other interventions. So, for example, there are some specific cessation type programs we cover under Medicaid. So a lot of these resources are braided in different parts of the system. So those resources are not neatly contained into all of our tobacco money being just parked here. It's sort of embed into a lot of programmatic and entitlement type programs. That being said, I do think it's important, given how close we are on budget cap, spending cap, that we, if we believe that this is an important program, I will note that traditionally, I think almost every year that the Tobacco and Health Trust Fund has met, even when it's had far, far fewer dollars, Quitline has always been funded through the Tobacco and Health Trust Fund. I think that mostly, I'll turn to Melissa for clarification, but I think over the last 3 years that we had money, we did about 1.6 million. So 500,000 is, again, a very small contribution in light of our historical spend. Melissa, do you want to provide a little more of a historical lens on the tobacco money that we used here to support Quitline?
Sure. So in the last 3 years, that Quitline funding was provided, and you can look in the back in the appendices of the evaluation retrospective reports. It breaks it down by year. $1.6 million was given to the Quitline. Prior to that, there was a $2 million year in there. And then there were some skip years where the trust fund itself didn't get very much of an allocation, maybe only received a total allocation of 800,000. And even in those years, some money went into the Quitline. But again, because the Quitline is funded by use, there were years where some money was able to carry over. So there was a year where Quitline didn't receive additional funding. So again, I think historically the $500,000 ask is way under what the Tobacco and Health Trust Fund provided in the most recent years. And additionally, I think DC Terra Nova's point from the beginning that we're only looking at this year. So once we have an evaluator in place and can look at the success of the Quitline and perhaps we can work into the RFP, looking at all the other funding streams that are available and how our money is braiding together with the other funding and initiatives happening across the state. we'd be able to make a more informed decision for next year about how we want to go forward and utilize those dollars.
Thank you.
DC Terranova, I'll turn it back to you for facilitating the next three questions and
Oh,
noting we're about 13 minutes, so we're running a little over on this section, but I don't want to truncate the important deliberation that we're doing.
Great. Suchitra?
Thank you, Deputy Commissioner. So I'll keep my comment short. So I think Quitlines are a great resource for the community, and we should find a way of supporting them. But I would really encourage you to do more on the communication side of things, because the Quitlines have put an enormous amount of effort into developing interventions, for example, for youth, but they're very poorly used, and most youth don't know about this and therefore don't access it. I think if monies could be put into expanding communications, that'll be enormously beneficial. And I also want to make sure that, because these don't work for certain populations, we don't know what kind of work has been done to reach out to minority communities, other diverse communities. We need to be careful and monitor who's using this and not take money away from other programs which may be directed at those communities too, including youth.
Absolutely agree. Thank you. Representative Harrison?
Hi, thank you for the question again. Being new, it's a lot of it is education, and making sure we have the right answers to do the right things. So my question, as I listen to the conversation is, sometimes with the allocation, we're only able to provide cessation products for 2 weeks. And I understand every individual is different, but what on average is the length of time that we would expect someone to have to use cessation products to be able to quit?
I don't know the answer to that off the top of my head. I do think it does vary, but I think that there's much better evidence that at least the 8 weeks helps the majority of the people.
Thank you. I see our good doctor shaking his head. Yes. So thank you for that. And I guess my point to asking the question is that we want to make sure we allocate enough money so that if someone comes forward and says, hey, help me, I want to quit, that we want to be able to give them enough to be able to get there. I think if, all we have is funds to give them 2 weeks, I could see where there becomes a frustration and they may never reach out again. So that's just my comment as we think about this allocation. Thank you.
Thank you. And I appreciate that. And I think, our ask is really of what do we need right now for this to start working on this current contract. And then certainly, I think we would appreciate the board looking as they, move down the road here and they have the full bigger picture. If there's more money to allocate toward this individual resource, we certainly would look for a way to use that appropriately. And so I think, for now, we would be very comfortable with the 500 to get us to a good place to start with our new contract and then leave it in the board's hands for future additional allocations. Tony Harp?
Sure. I was wondering because we have 40% going to, well, at least the CDC does, to cessation interventions. Besides the quick line, what else are we looking at, or do they normally recommend funding?
Yeah, so I think like Suchitra was mentioning, kind of other things that target youth, especially for, vaping programs. Some of it is promoting system changes, so including insurance coverage and other efforts to help increase and improve cessation rates. So not necessarily directly helping an individual to quit like the Quit Line does, but what are kind of some bigger system changes that can help encourage and sustain cessation. So some funding goes to those types of activities as well.
Yeah, I guess I would recommend that, since you just want 500,000, which is not a lot compared. And I'm just wondering if we could put more money into communications and into community interventions to deal with some of the disparities that exist.
Great, that's a great point. Did you have a recommendation for an amount that you wanted to kind of further discussion on, or?
Well, you know, one of the things that I was wondering if we could add dollars to, because now, am I wrong? We're getting $12 million, right?
Right, right.
Yeah, so I mean, I think 40% with sort of knowing that the 500,000, which I certainly don't have a problem with, works, but the other things are a little more what I would consider to be mushy. I would add to community interventions 5% out of that, and another 5% I would add to communications.
The cessation down to 30, state and community up to 40, and communications up to 17.
That's my recommendation.
Okay, great, thank you.
I don't know
Dr. Zellner?
I would be in favor of leaving the numbers as they are. In the past, under interventions, Tony, we have funded specific programs for disparate populations, such as people who are coming out of the Department of Corrections or people in various communities that are underserved that need a focused cessation program specifically aimed at them. And I think if we cut it back, we miss the opportunity to reach underserved communities with a focused cessation program. So I would not that communications or community interventions and prevention aren't important, but if you look at the evidence base for having an impact on the burden of tobacco on society, cessation happens to have some of the highest evidence-based outcomes in terms of success, and that's why I would lean against limiting our cessation numbers.
Thank you for that perspective. Suchitra?
Yes, I agree with what was just said. I think one of the ways we could handle this would be going back to the quitline discussion, would be to allow for an amount that comes out of the mass reach health communication part to support health communication about the quitlines. That would be one other way we could do this, to have quitlines have the 500,000 to support their contract, but also have additional dollars through health communication if the committee is agreeable to something like that.
Thank you. Claudio, I'll turn it back to you.
Thank you, DC Terranova. I just want to, Melissa has some examples, and I want to call on her to just help illustrate, I think, the conversation that we had between how communication fits in, and maybe it isn't as neatly siloed in one category. So Melissa, if you can give us by way of some examples, I think would help the committee.
Yeah, sure. So historically, I think it might be helpful to understand that these categories, although targets, there is some flexibility and overlap. It's not like communication and equity can only occur in one category or another. So in looking at what the previous iteration of the board has historically funded under cessation programs, there was a focus on programs to contractors to provide services to underserved populations with high rates of tobacco use, including communications and community-based outreach cessation programs, providing, targeted populations with specific outreach and cessation. Also, campaigns focused on specifically young adults, and prevention among youth was part of it. And there was also some cessation funding provided for, I just lost my place, but it was for ongoing to stop with recidivism. So to help people to be successful and to provide tobacco evidence-based cessation assistance to those who want to quit and helping to reduce recidivism. So the group in the past actually even looked at underserved and uninsured populations. And I think that's, and then again, as Dr. Sollner said, had the special program that supported DOCs, Department of Corrections, smoking cessation programs. So historically through cessation intervention programs, we've bred in the equity lens, using the RFP to target specific populations and to increase outreach and to those specific populations, and to also address recidivism rates with people that engage in cessation programs to try and make sure that they don't go back to smoking or reduce the chance of them going back to smoking. So I hope that's helpful.
I do want to recognize DC Terranova, if you could help us think through, because there was a suggestion made by the board here to consider not only the 500,000 that's needed programmatically for the quit line, but some carve out of the communications that will help drive better utilization and information and awareness. Is it your understanding that if we allocate additional money that the quit line as a vendor could not only do the program, but also put together a communications plan with money if we provide that?
Yes, that could happen. I would also say we could also include that in the RFP when we put it out as well, that a communication piece around the quit line, you know, if there was another communication company that wanted to provide that campaign for us. So I think, you know, we could do it either way.
Does the board, I want to close the loop on that because I thought that was a good suggestion. So does the board have a preference of which way we do it? I think there was consensus that driving some additional communication and attention to the valuable work of the quit line is worthwhile. Do we want to carve out a specific dollar amount here, or just direct DPH and the RFP committee to build in as part of the standards for the 12% some quit line communication and support dedicated? I'm seeing nodding heads for the second, which is the RFP for the communication would just make that a priority area. Okay, good. Anne, your hand is up, and then maybe we're at time, but maybe if people can indulge for another 5-10 minutes, we can maybe try to get some votes finalized.
No, I don't need to speak. I just wanted to weigh in on the side of using the communication money to drive people towards quit line. We tended to do that last time around, that whatever mass reach health communication we had, at the bottom of it was kind of a tagline, call quit line, and here's the number.
I love that idea, because this way it'll maximize all 12% towards quit line, double purposing. That's great. Good institutional history on that one too. So then I think the motion is, DC Terranova, yours to make about the 500,000.
Sure. I would recommend that the board designate $500,000 to the quit line.
Motion made. Is there a second?
I'll second it. It's Tony Harp.
Tony Harp seconded. Do we need to take a roll call, Melissa, or can we do this by voice vote?
By voice vote, it's fine.
All right. So then all those in favor of allocating the 500,000 for quit line, please signal by saying aye.
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 Any opposed? Abstention? Seeing none, the motion carries.
Thank you.
Next, I want to entertain a motion. It seems like we've not decided to make changes on this, and that for our first iteration as a board, we're going to stick to the default positions on the categorizations, knowing two things being true. One, there's some flexibility in these categories, so we can have that as a an ability to maneuver if we need to. Two, I'll remind the board that statutorily, when we submit this plan to the Appropriations and Public Health Committee, we're allowed a small discretionary window of 50,000 or 10% variation in our allocation plan. So we have a little bit of room. I don't want us to think that we're so prescriptively tightly wound that we have no room for error. There's a little room for error in there. So understanding that, is the committee agreeable to accepting the default CDC best practices percent allocations as shown here on the screen? Do I have such motion?
So moved.
Robert moved, second.
I'll second it, Tony. But can I ask a question?
Of course.
Um,
Go right ahead, Tony.
never mind, I'll ask it after the vote.
Okay. All those in favor of adopting the allocation plans for the CDC best practices as presented here and as are the standard for CDC best practices, please signal by saying aye.
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 Any opposed? Abstentions? Seeing none, the allocation proportion are adopted. Senator Tony Hart.
Okay, sure. I was just wondering, in terms of what the next, could you define, I'm new, the next process in terms of figuring out among all of these categories, what exactly is going to be in the RFP? Is that next, or is something else next that I need to know
You
about?
perfectly teed me up for item number 7, and I love that. So that's great. Just quickly on next steps. One, with respect to the funding allocation plan, we will reconcile this, put it into some form that can be transmitted to the committees of cognizance. That triggers a 30-day review period. The committee will inform us of whether they accept, modify, reject. If there's a split between the committees of cognizance, there's a process for setting up a conference committee, and then a conference committee report being an up or down vote. If ultimately there's no agreement being able to be reached by the legislature, our position as the default would carry. I assume, as has been in the past, it's been a pretty collaborative process. So I would expect that they would either approve it or make the modifications, but that we would do so in a pretty quick order after we submit it to the legislature. It also helps that we've had some really robust conversations with stakeholders. Our public meetings have been well attended. There are legislative partners that have been part of this group. So hopefully that will help for a good, smooth process for evaluation in the legislature. The second piece is, once we do receive approval from the legislature, to Tony Harp's point, we will then ask DPH to set up an opportunity for any member here on the council that wants to be part of an RFP scoring or writing committee. So there are two distinct opportunities that will be presented. One, you have to obviously not have a conflict of interest. So if you're applying for dollars in a specific RFP category, we'd ask that you not be party to writing the RFP or scoring the RFP. But upon getting our final formulas approved by the legislature, DPH will initiate a process of accepting volunteers from this board. The first subset of volunteers will work off of a template that's agreed to by the state, with an opportunity to spec out the scope of services, the categorizations that we look to fund, and any specific details that we're seeking on that RFP process. That there will be another volunteer opportunity for those who don't want to write the program or help write the RFP solicitation. Folks can choose to be part of a scoring committee. If we decide on the scoring committee, then you would ask to be signing confidentiality forms. You would go through a formal process of evaluating. There would be some group scoring, and then ultimately a decision to award based on the committee's consensus recommendation and scoring. So we have a dedicated person at DPH who is willing to be the coordinator of this. It's Shanna Jones. We'll send her email and contact information out to the board when appropriate for soliciting the volunteers. But just know those are two very substantive areas of opportunity for board members to engage in the details of a lot of the discussion we had today. How do we secure and ensure that the funding we're supporting is braiding into existing programs? How are we targeting across different equity measurements and looking to address disparities. How are we looking to build in the quit line into our communication strategies? All of that is most appropriate for the scoping of our RFP solicitation and the evaluation thereof of the applications we receive. So does that answer your question, Tony?
Absolutely. Thank you.
Great, thank you. Are there any other comments? I know we are a little over time. Yes, Anne.
I am sorry, I know we're over time, but you just reminded me when you spoke about the little bit of room that we have with regard to moving funds from one category to another, if something necessitates us doing that. And I do recall from last time around that $50,000 was quite tight and quite difficult. And so I know we talked last time that the administration may be going forward to make some minor changes with regard to the legislation, our statutory authority, just, clarifying the chair, who's the chair. And I would just ask that you give some thought to upping that authority to move from one category to another. We just don't want to let, $75,000 just sit there because we can't get it out in one category and we could have moved it. So I would just ask you to consider some legislative change to make that a little bit higher than it currently is.
Good point. Yes, I think that we'd be more successful at doing that, having gone through one round and showing how tight it is and how that is a barrier to us doing the work that they want us to execute on substantively. I know that this language is not unique to the Tobacco and Health Trust Fund. It's similar to what we use for FAC actions and similar to the block grant. So it does have some legislative precedent, but totally agree that to the extent we can get some flexibility, knowing that we're going out to competitive bid for these. So it's a little different than programmatically budgeting for an agency where we have some history and some good data on what to expect and how we can anticipate different costs. Same with the block grants. A lot of those are very steady over time. I could see this being a dynamic category. So as the board looks for that legislative change, I think it's going to be helpful if we can make the case of distinguishing this and the guardrails they put on this funds from other funds. All right, last item is a motion to adjourn.
So moved.
Thank you, Andrew.
Second.
By Michael. All those in favor, please signal by saying aye.
Aye.
All right. The ayes have it, and we are adjourned. Thank you.
Thank you.
Thanks. Have a nice day.